session. So I have exams in 10 days. I can't focus, so let's study together. So I wish to complete now epidemiology of. Let us see some like topics. Okay, I want to read paper 2 first. So I have to complete epidemiology of communicable diseases. Is it clear? Okay, I want to complete epidemiology of communicable diseases. Then I wish to complete non-communicable diseases. I wish to complete communicable diseases, non-communicable diseases, and then health programs in India. So I want to complete these three major chapters from paper 2. Remaining all you can manage. So I read only from yesterday and today. I read only TB, polio, cholera, typhoid, hepatitis, and food poisoning. So we'll just read together about now malaria. So I want to read like not malaria but AIDS because it is first in this book. So we'll read targets, diagnosis, and management. So AIDS. AIDS is run by NACO. NACO means National AIDS Control Program. It is in the Ministry of Health and Family Welfare. World AIDS Day is December 1st. We all know that. And epidemiological determinants. So what are the agent factors, host factors, and environment factors, and vulnerable occupational groups also we'll see now. Agent factors, we have lentivirus. It is single stranded RNA virus. Protein GP120 and 41 and P424 RNA virus. It is lentivirus and it has an enzyme reverse transcriptase, which it can convert genetic transcription means transcription means mRNA to so reverse transcription in the sense guys the conversion of DNA to RNA. Generally RNA is converted into DNA in transcription, we all know that. I'll just Google it about that. So DNA to RNA is transcription, whereas reverse transcription means from RNA to DNA.
అదే వాళ్ళ తమ్ముడు చచ్చిపోయి ఇంకా బాగా కూలిపోతున్నాడేమో నాకన్నా ఇదేమో.
So alcohol and disinfectant sensitive. So this AIDS organisms, which is lentivirus, can be destroyed by alcohol and disinfectant, and it is resistant to radiation, which is very like you all know with chemotherapies, we cannot prevent the disease once the disease gets to us. So what are types of HIV virus we'll see now? HIV 1 and 2. HIV 1 is most common in India. HIV 2 is most serious and most common in Africa. And we also know that the origin of like HIV is in Africa. So groups of HIV 1. We'll see the groups. So MOPN. M is a major, most common in India. It has subgroups like A, B, C, D, E, F, and C is the most common. So in HIV-1, M is major group, and in that M we have C as a major group, and then we have O, outlier, P probable, and neither major or not outlier. So we have majorly four types of HIV groups, which is MOPN, MOP, and N. We can remember by MOP and N. So M is a M means as a mnemonic, we can remember it as major, and most common is C. HIV 1 is most common, and in that M is most common subgroup, and C is most common subgroup. Okay, and then we have mode of transmission. We all know it is through sexual intercourse and blood. So efficiency and effectivity. Efficiency means chance of infection in ideal situation through blood, and effectivity, chance of infection in particular situation. So we have to know the difference between efficiency and effectivity now. Guys, we'll know the difference between efficiency and effectivity.
నీకీలా
I'll just Google it about efficiency and effectivity.
ఎంత అయినాయి ఎంత పదివేలు ఖర్చు పెట్టింది. మొత్తం 10,000 ఖర్చు పెట్టింది. పెద్దలు మంచిదిలే. అదే మంచిదేలే 10 మందికి. మంచిదే, ఆమెకి ఎట్లా ఓపుకుంది పంచుతుంది. ఏమైంది?
Okay, guys. So efficiency and effectivity means efficiency means in ideal situations, which means not real. Which when we do a plan or make a plan about some drugs to be used in society, we can decide which whether it is efficient or effective. So most efficient route is blood, which is 90 to 95%, but effective. But in general, mm, effectivity is in practical situation. We can remember by T and T in practical situation. It is 70 to 80%. So blood, perinatal, IV drug abuse, and realistic injury. Then we see host, majorly 20 to 50 years. Increase susceptibility in females due to large surface area of exposure in females. Concentration of HIV in semen, it is more than vaginal secretions. Anal intercourse, 3 times more transmission than vaginal or oral intercourse because of more abrasions through anal intercourse or oral. Adolescent postmenopausal women due to thin mucosal lining. So these are most susceptible, adolescents and postmenopausal women, due to their thin mucosal lining, and sexually transmitted diseases. Uh, Increase in T cells, increase blood in genital area, increase spread. So not only like AIDS, HIV, other gonorrhea, or other sexually transmitted diseases. What are the examples of other sexually transmitted diseases? Like gonorrhea, Listeria gonorrhea, we'll just see.
మనిషి కంగారు ఉందా ఏంది కంగారు ఉండడా
HPV, human papilloma virus, or genital herpes or chlamydia. HPV, genital herpes or chlamydia. So they have more T cells, more blood in genital area, so there is more spread. So window periods, which have more viral load. Window period in the sense a period in which patient is asymptomatic even though he's infected, and he has so much of infectivity during this period, and it shows iceberg phenomena because it is a subclinical stage. And note, saliva secretions have the lowest concentration of HIV. And vulnerable occupation groups, so single male migrants, truck drivers, or female sex workers, or male sex with a male with anal intercourse, long distance truck drivers. So clinical features. What are the features we observe in the AIDS patient? So generally we observe three stages. So stage 1 is asymptomatic, generalized lymphadenopathy, size more than 1 centimeter, duration of more than 3 months. So we can see that this is a window period where patient is asymptomatic, but there is a lymphadenopathy, increase in size of lymph nodes, which is more than 1 centimeter, and duration of more than 3 months. And stage 2, a weight loss of less than 10% of body weight. So weight loss is a major also a major feature. Mild infections, mostly surface infections, and angular cheilitis near the lips, recurrent oral ulcerations, and papillary pruritic eruption, and nail infections, respiratory tract infections, sinusitis, tonsillitis. These are infections because there is an increase in immunity in HIV patients. So in stage 2 we have angular cheilitis, oral ulcerations, papillary pruritic eruption, nail infections, respiratory tract infections. So stage 3 is weight loss of more than 10% body weight. In stage 2 we see less than 10% of body weight. You have chronic diarrhea, the patient will have a persistent fever. These are cardinal features. Weight loss of more than 10% of body weight, chronic diarrhea. We also see body weight of more than 10% in TB, right? And then we have a chronic diarrhea and persistent fever, infections in deep tissue organs or tissues, which is meningitis, which infects meninges of brain, bone and joint infections, pneumonia, pulmonary tuberculosis. It is the most common opportunistic infection, persistent oral candidiasis, which is in candida, and unexplained anemia due to low immunity. So what is the clinical features of HIV, guys? We have three. They have three stages. Stage 1 is asymptomatic window period, but there is a generalized lymphadenopathy for 3 months of more than 1 centimeter size increase. And we have stage 2, in which we have a body weight of less than 10% of body weight loss, and fever and diarrhea. These are cardinal features. Sorry, so in stage 2, we have a body weight of less than 10% and mild infection because decrease in immunity. Which means angular cheilitis, oral ulcerations, and papillary pruritic eruptions, nail infection, respiratory tract infections like tonsillitis and sinusitis. Stage 3 we have more than 10% of body weight loss, and chronic diarrhea and persistent fever, and infections in deeper tissues, which is meningitis, bones and joint infections, pneumonia. TB is the most common opportunistic infection in HIV patients. Persistent oral candidiasis. So we have to remember the cardinal features: diarrhea, fever, weight loss, and explained anemia. We have stage 4 also, which we get people get cancer. Most common cancer is Kaposi sarcoma, which is B cell strongest association, and non-Hodgkin's lymphoma, and opportunistic infections like extrapulmonary TB. In stage 3, we observe pulmonary TB, which is the most common opportunistic infection we see in HIV patients. And then we have C cytomegalovirus, recurrent septicemia, extrapulmonary cryptococcus infection, cryptosporidiasis, isosporiasis. These are fungal infections. And targets are increased increase incidence by 80%, and to decrease deaths by 80%, and to eliminate vertical transmission of HIV and syphilis. Vertical transmission in the sense a transmission of HIV or syphilis from mother to baby. So promote universal access to quality sexually transmitted infection or services, and eliminate HIV related stigma and discrimination. So these are 5 targets: mainly decrease incidence of HIV by 80%, or decrease deaths by 80%, and eliminate vertical transmission of HIV or syphilis, and increase medical facilities, universal access to quality services of sexually transmitted infection services, and eliminate HIV related stigma and discrimination. We all know the stigma faced by our society, but after um, we know that we that I can't remember that.
అప్పుడు అప్పటికే తీసేసారనేసరికి వెనక్కి వచ్చాం. అది సంగతి ఏమనుకోకు, ఊరికి రావట్లేదు.
Diana gave a shake hand and hug to HIV patient in Africa during her world tour, which created a more awareness among people that it is not by contact spread. It doesn't spread by contact. So we have to eliminate HIV related stigma and discrimination, and provide and treat them with proper care. And strategies is 95 95 95 95 strategy, which means 95% of all expected people living with HIV should be diagnosed, 94% should be on treatment, and 95% should have adequate response to treatment, and more than 95% should have a good quality of life. First of all, they should be diagnosed, and they should be properly receiving a treatment, and third thing is to decrease their viral load, and the fourth thing, they should have a good quality of life. Then we have management we have screening and diagnosis. So in screening we have ELISA. This is investigation of choice. ELISA means enzyme linked immunosorbent assay, and chemiluminescence immunoassays. CLIA, ELISA CLIA, and particle agglutination and immunoconcentration, not commonly used. Immunochromatography, rapid test or lateral flow test. Diagnostic, which are gold standard. So DNA, RT-PCR. It polymerizes, multiplies the viral particles in our body. It is gold standard in children. qPCR, quantitative PCR by nucleic acid, which means NAT, nucleic acid amplification test. Investigation of choice in adult. Viral isolation or viral load estimation is gold standard.
నేను ఎందుకంటే వాళ్ళ పెళ్ళిళ్ళకి కానీ ఎవరికి దేనికి పోలేదు. ఏందులో చెప్పేది మనకు రావట్లేదు అనుకుంటారు మాట. వాడు వేసుకోకూడదు దగ్గర నా నెంబర్ ఉంది, ఆడు పోయి పిల్ల కొద్దిగా ఫోన్ చేసి వదిన అంటావా అప్ప అంటావా అప్ప ఫోన్ చేసి పిల్ల వచ్చిందిలే ఫోన్ చేసి అని చెప్పి మనోడి చేత. అదేలే మీ ఇంటి పేరు ఆ ఇంటి పేరు ఒకటే కదా.
Viral isolation or viral estimation is gold standard.
సరే సరే ఉంటుంది. ఆరోగ్యం జాగ్రత్త చూసుకో, పని పరిగెత్తుకో పక్క వాళ్ళతో పాక్కొలత పని పక్కన పోల్చుకోబాకు. నీ ఆరోగ్యం వాళ్ళ ఆరోగ్యం నీ పాటికి నువ్వు దీనికి అమ్ముకుంది వాళ్ళు పరిగెత్తి
So screening is ELISA. Screening we have to do 3 tests. First ELISA and plus any 2 other screening tests like immunoconcentration, CLIA, particle agglutination. Test of choice is ELISA more than triple testing. So probable HIV scenario, if you see blood donation, positive screening test, if 1/3 also respond, discard blood. Strategy unlikely unlinked anonymous test. Symptomatic person,
సరే అయితే.
so in blood donation we have to do, even if one screening test is also positive, we have to discard test and some we have to leave the symptomatic and asymptomatic. We have to, even if in symptomatic 2 tests are positive or in symptomatic 3 tests are positive, we have to count and refer for confirmation and out of testing. All blood donation should be screened. Subject can choose to be informed of HIV status. And opt-out testing for primary prevention in the fetus and routinely done in ANC unless mother has opted out. So in antenatal care we have scans, right? So we have a screening for HIV in mother to rule out transmission, vertical transmission. So if it can be routinely, it is opted, but unless mother doesn't get interest of HIV screening. So regimens, which is treatment. So for age more than 10 years or of weight more than 30 kgs, we give TLD. TLD is a preferred regimen, which is tenofovir, disoproxil, fumarate plus lamivudine, dolutegravir. Tenofovir, disoproxil, fumarate, tenofovir, disoproxil, fumarate, tenofovir, disoproxil, fumarate, or lamivudine or dolutegravir. It is fixed dose combination at the same time every day. It means if patient have a like, see, if a patient has taken the drug at 8 o'clock in the morning today, he have to take the drug tomorrow at 8 o'clock. And contraindications of TLD regimen, which is tenofovir, lamivudine, dolutegravir. How to remember this? Tenofovir, disoproxil, fumarate. Tenofovir, which have affinity, so last is fumarate, disoproxil. Oh, tenofovir, disoproxil, fumarate. 300 mg, 300 mg, 50 mg. So contraindication less than 10 years of age, low weight, renal and hepatic dysfunction. So we have conditions for TLD regimen, and 6 to 10 years we have ALD regimen, and less than 6 years or less than 20 kgs we have AL, LPV or R. RAL. What, mom? ALD regimen for 6 to 10 years of age or 20 to 30 weight. We have abacavir, lamivudine, dolutegravir. So, and for less than 6 years of age, So TLD, ALD. So for less than 6 years of age, we give AL, LPV, RAL regimen generally, which contains abacavir, lamivudine. Lamivudine have LPV or R regimen, right? So we'll just remember as RAL. We have no more time, so we read raltegravir, abacavir, or lamivudine. Raltegravir, abacavir, or lamivudine. So to prevent so I'll tell you the treatment now. For less than 6 years of age and less than 20 kg body weight, we'll give RAL regimen, which is raltegravir, abacavir, or lamivudine. And for age 6 to 10 years of age or 20 to 30 the kgs of body weight, we'll give ALD, which is abacavir, lamivudine, dolutegravir. And for more than 10 years of age with more than 30 kg of body weight, we'll give TLD regimen. It is ALD, TLD, tenofovir, disoproxil fumarate, which is 300 mg, and lamivudine 300 mg, dolutegravir 50 mg. We have prevention of mother to child transmission, which is vertical transmission. There's a strategy to like eliminate complete mother to fetal transmission of HIV target. So how to eliminate this we have to see. So at birth there's low risk of transmission. So there's a risk, but even though it is there is a low risk. So we have to give medication because there is no risk. So nevirapine is the drug of choice for at birth. For child, which is orally for 6 months, 6 weeks. Weight gas will see. So the mother should not baby, but the mother should take nevirapine 10 mg for OD for 6 weeks, and in high risk transmission, which contains a criteria of newly diagnosed mother of less than 6 weeks of delivery. Through breast milk, it may transfer. So ART insufficient mother, which means who took antiretroviral therapy of less than 4 weeks, and they have high viral load in mother, which is more than 1000 copies of RNA per ml after 32 weeks. We have to give a dual prophylaxis, nevirapine for 6 weeks OD and zidovudine 6 to 12 weeks. So prevention, this is like this, and early infant diagnosis at 6 months, 6 weeks. Investigation of choice is HIV, DNA, RT-PCR. So RT-PCR is most gold standard diagnosis in children, whereas in adults it is qPCR for viral isolation or viral estimation. So HIV negative 6 months follow up for 2 years. HIV false positive ART. So in breastfeeding guidelines, Nivirapine, Zidovudine. Breastfeeding guidelines. So exclusive if in HIV negative in mother or HIV positive, exclusive breastfeeding for 6 months we have to give, and in HIV negative people baby we have to continue for 1 year. In HIV positive baby we have to continue for 2 years, because we should not stop breastfeeding because it has a more immunoglobulin in protective factors, and abrupt stop may not be advised. And vaccination of infant born to HIV positive mother, all due vaccines are given at scheduled age as per national immunization schedule, but there is a contraindication of live vaccine if HIV symptomatic baby or CD4 less than 200 cells per millimeter cube. Opportunistic infections like TB, relative CD4 count is less than 15%. So, in such cases, OPV is contraindicated in sibling of immunocompromised child due to VAP risk, which is vaccine associated paralytic polio. We have two: vaccine derived poliovirus or vaccine associated paralytic polio.